I think you.
I think you subscribe to the channel when you join as a panelist. Just check in your other Google and other things.
Browser.
Maybe
Yeah.
the YouTube thing is open, I guess, in your computer.
Even we are hearing your sounds.
Your video or coxid I am hearing.
Yeah, that's what I'm saying.
Just close that YouTube screen.
Yeah, switch off the other screen. Yeah, okay, great. So thank you, Dr. Monirul, Dr. Sasmit, Dr. Sanjog, Dr. So Dr. Sunny, you need to switch off all the other windows. Right now I've muted you because it's coming, the sound is coming from your side. So let's start now, guys. We are already just beginning. So welcome to this pain debates. This is the fourth such debate which we are conducting, and the other three you can just watch on our YouTube channel. So guys, this one is a very special one because I started conceptualizing this one as soon as somebody told me that they are not very essential. So I thought, now let's have a debate on this. So today we are going to have a very distinguished speaker who is going to speak against, as well as who's going to one distinguished speaker who is going to speak for the topic. So Dr. Sunny Malik is MBBS, DA, DNB, MNAMS. I think this is member of National Academy, and this is FIAPM, FIPM, lots of degrees to his name. He's consultant in charge for Department of Anesthesia, Pain and Palliative Medicine at the Rajiv Gandhi Cancer Institute and Research Center at Niti, Bagh, South Delhi branch. He's got lots and lots of achievements, which includes being faculty at various conferences, being active at IAPM, being the active member at his ISSP Delhi meet, also the editor of one of the journals, which is the Annals of International Medical and Dental Research Journal, also the editorial board member of Indian Journal of Pain, and lots of very decorated anesthesiologists, lots of awards to his name as well, including the Excellence in Pain Medicine Award, and also he's got 2 book chapters as well. So welcome, Dr. Sunny. Our other speaker today is Dr. Dhruv Bibra, and he's also a very decorated speaker. He's got his DA, DNB, FIPM. He's managing the Delhi Pain Management Center with his presence at 7 centers across the NCR. He's also a clinical advisor and visiting consultant at various hospitals, which range in various states, in fact, of India, and they're very far apart. So I think he's covering the widest reach anywhere in terms of clinical practice, I think, what I have seen in the country. And also he's got and he's also a clinical advisor and visiting consultant to Dhaka Pain Management Center at Bangladesh. Academically, he's contributed 2 chapters and he's been a contributing author in a book, and various publications in various peer-reviewed journals are there. He's also an organizer of India Pain Update from 2016 to 2019, as well as in 2021. It's a regular program which is being held since last many years, very popular one. So before we go ahead, let me introduce the debate format to the audience, and then we move ahead. We are going to have the login introduction, and now we're going to start with for the motion. There are 10 minutes. Dr. Dhruv will present the for the motion topic, and against the motion will be represented by Dr. Sunny Malik. We will have a rebuttal, and this rebuttal the first chance for rebuttal will be given to the speaker who is speaking against the motion, that is Dr. Sunny. And after that, we'll have a rebuttal with Dr. Dhruv, and we'll follow the same process. I will get the first chance to speak, to ask the questions, and thereafter the audience questions will be there. So I think Dr. Aanchal and me will ask the questions which are the moderator questions. Then after that, we have the audience questions as well. And thereafter, we'll go to closing comments and we'll end the debate format. Okay. So here are the rebuttal rules. Dr. Aanchal, would you like to read them out for me? Yes.
Sure. So for the rebuttal rules are attempting to defend the opposing arguments and to defeat the supporting arguments. So without adding any new information. So we already the facts. For example, you should start like, first, let's look at what we heard from the previous speaker and disagree with their points. So please choose 3 points or less. And point 1 is like, now on to my points, for example, name XYZ and explaining the reason why your point is true. And what does it mean for your overall position to say that you're right? And you can present evidence in form of facts, analogies, examples, imagery, or authority to support your reasoning. And point 2 is same, name, explanation, evidence for the same, and similarly the point 3.
Great. So I think the important point is to remind the audience of the 3 points you have covered in the end. And please remember that this debate is going to be almost eternal and it will be viewed many number of times. So just make sure your rebuttal is very powerful. So just a small request to both the speakers, please stick to your time. And for the audience, we have some house rules. So questions are most welcome in the chats. You can type in the chat box, raise hand to speak, and only one person should speak at a time. So just raise your hand, I will unmute you. And probably you can speak then, and you can also put your question in the chat, or also there's a Q&A special feature in this webinar, and you can just put in there as well. So I think this is it. So over to Dr. Now we are going to listen for the motion speaker first. So over to Dr. Dhruv. Dr. Dhruv, can you share your slides now? Yes, so you can unmute yourself now, and I will just set my stopwatch. Your time starts now.
Good evening, everybody. For decades and decades, we have struggled with cancer pain, and it has been a nightmare. But the journey slowly and gradually has become positive, more positive, and finally we are at a position where we can actually help our patient in a positive and a meaningful way with minimum or less dependence on drugs by these minimally invasive interventions. I would like to welcome you all for this wonderful debate and Dr. Sidharth for giving me an opportunity to speak for the motion. I will be covering the topic in I will be making just 3 basic points to support my argument. Starting with the first point. Now, it is high time that we accept the new updated WHO pain ladder. Now, the pain ladder was introduced in the year around which I was born. Until that time, it was one of the best things. But as the technology has evolved and as the challenges of managing the cancer pain has evolved, the number of cancer pain has evolved, now it is high time that we move on to the 4th step. So, but first and foremost, why was there a need of having that 4th step? Now, the design of this ladder was basically meant that the general public or maximum amount of non-medicos or nursing staff or general practitioner could practice. But what we found out was that what was actually happening is that more and more specialists were being referred cases which were mismanaged because at the ground level, the people were not very comfortable with the drugs, mostly opioids. They were underdosing it or overdosing it, unable to manage side effects and creating new side effects. And that is why there was a proposal of adding a 4th step, which eventually did happen. And now it is widely accepted, where the 4th step is where they have included invasive and minimally invasive treatment as a part of cancer pain management. Now, that is one point. And second interesting thing is, when we were trying to discuss about the standard WHO pain ladder, it was a unidirectional, meaning that one will lead on to the second will lead on to the third. But with this revised pain ladder, it is a bidirectional flow. So what it means is that if you feel that the patient is having severe pain and requires an intervention at your first meeting, you go ahead and offer it, rather than waiting and going and wasting your time, energy, manpower, and all of that. So now, my dear friends, if it has become a gold standard, we should accept it. And once we accept it, then only we can work to improve it and make it more practical, more viable across the length and breadth of the country, rather than debating about a point that whether it is good or not. It was essential, it is essential, and it is going to be essential as the time goes on. Now, point number 2. My revered friend, Dr. Sunny, will talk at length about opioids. But we have to admit that there are challenges with opioids, which are supposed to be the gold standard or the alternative to these interventions. Now, what are these challenges? You will be surprised to know that legally you can cultivate opioids only in 3 states: Uttar Pradesh, Madhya Pradesh, and Rajasthan. And majority of these opioids is being exported. And when I talk about majority, I'm not talking about 50 or 60%. I'm talking about more than 90-95% of the opioid is being exported. So to cater to more than 1.4 billion people, you have such a small amount. That is one challenge, the production challenge, availability to our population. Second is the legislative challenges. Now, every state has a different legislation, because of which the availability or the supply chain of the drug is grossly hampered. Third is that poor pharmaceutical guys or the distributors, because there is so much of paperwork involved, are very reluctant to keep these drugs. Second, they are harassed by the law enforcement agencies. Hence, it is quite challenging for us to convince them that you have to have adequate supply of all the opioids if we have to provide comprehensive cancer pain management. Now, my friend Dr. Sunny will talk about that. Yes, we can bring about these legislation. I also thought about it for a long time, and luckily I came across a paper by Padam Shri Dr. Rajgopal, who has done extensive work when it comes down to palliative care and who is a big proponent of opioids. In that, he said that he conducted workshops in 13 states of India. And after so much of efforts, there was some very little positive changes in only 6 states. And this was in the year 2007-2008. And everybody in the panel and everybody listening would agree that from that year to now, we are at a position where the laws have become more stringent. For my patient, say from Punjab, he cannot procure a simple tramadol tablet. So how can we expect them to be dependent on morphine? Don't we think that it is more advisable if there are trained doctors, pain physicians within the state who can provide them pain relief in their own state, so that their consumption of opioids is reduced? So that is one. So now the opioid is not in the picture. So now the third thing which I often hear about is that people have a lot of inhibitions about the clinical efficacy and the cost effectiveness about these interventions. Now, I would like to be very specific that with each passing day, lot of data, positive recommendations are coming for each and every intervention that you can think of. I have done. I have the best guidelines which have come up in the recent past have come up from the ASPN, American Society of Pain and Neurosciences, where they have tried to talk about all the interventions possible, and for most of them they have given good level of recommendation as high as 1A. So it goes beyond doubt that these things are highly effective clinically to bring about a positive change in the pain scores, and in the long run bring about a meaningful change in the day-to-day activities of the patient. Okay, now the last point the last point is about cost effectiveness. Now, the common myth or the common thing which is circulated in the market, both within our fraternity as well as among oncologists, oncosurgeons, is that your interventions are highly costly. Really, do you think so? Do you have any data? Unfortunately, no. The only data of cost analysis which I have come across in the literature is only restricted to the Western world. And everybody sitting here who have worked in the outside world, they know that when it comes down to interventions, we provide the best quality interventions at the most affordable rates. So those kind of data cannot be extrapolated to our population. Unfortunately, we do not have our own data. But what I have tried to do is I have just tried to do this is a proposed cost-effective model which I have proposed. This is open for debate. But yeah, so now what I have said is that you can divide the costs into or the advantages of them in 4 categories. One is a direct cost. Direct cost, definitely a medicine, you prescribe a medicine versus a intervention, definitely the intervention cost is going to be more. But the indirect cost, now my friends would ask, what exactly do you mean by an indirect cost is, for example, if an attendant has to, for example, go with a patient or procure a medicine for the patient every time, and he has to take that leave, that also counts as an economic burden. Second thing is, if you prescribe more drugs, there is bound to be more amount of side effects. To counter those side effects, you will have to go for more amount of drugs, which just adds to the cost. Along with that, the cost of sometimes overshooting and undershooting, which may lead to sort of unnecessary hospital admission, again adds to that indirect cost. Because of all these, the chances of healthcare infrastructure being stretched because of frequent visits, it may not be to a hospital, it may be to a simple pharmacy, but yes, the dependence on it. And my dear friends, again, I'm giving you an example of a state and something which we discussed while we were discussing this topic, that there was a time when people used to travel as far as Patna to Delhi to get their dose of morphine. So you just imagine for a poor chap to travel for a tablet, which is not costly, but the indirect cost makes it extremely costly. The better option for that is definitely the MIPS being part of the essential care and those interventions being done at that rate. Dependence on family support, obviously. A drug which has to be given 4 to 5 times will have more dependence on the family, rather than if by interventions we can cut down the amount of drugs even by say 20%, 30%, 40%. That one dose, reduced, actually goes down in a very positive way to reduce the familial psychological stress. So overall, definitely, when it comes down to clinical evidence and cost effectiveness, the interventions definitely has a greater advantage over medicines. Now, I would just like to my closing remarks. Now the thing is, during the talk, I've already told you that we have an option which is safe, which is effective, at the same time economically viable. Comparing it to a subject, comparing it to something which is dubious, which has got lots of loop and holes in their supply chain demand, where rather than training the doctors, we have to chase the politicians and bring about a change in the legislation, which is already a part of the major guidelines. It is high time we accept it, admit it, and work towards making it a success. I agree that a lot needs to be done, but the first thing for any change is accepting that yes, there is a lacuna. Therefore, I strongly would like to say I am for the motion of including MIPS as a part of essential care, cancer pain management. Otherwise, the option is for you to decide whether you want to stay in the dark or accept brightness. Thank you so much.
Great. Thank you, Dr. Dhruv, for the presenting your point of view. And I think those light effects were awesome. Now let's move on to the other speaker, Dr. Sunny Malik. Dr. Sunny, I will now request you to just start sharing your screen, and I think you can, yes, so we can see your screen now. Yes, so you can also switch on your video because we can't see you yet, and also you can unmute yourself because right now you are muted. Yes, so you can switch on your video as well.
Just a minute.
Yes. So I
Yeah.
can see you
Now.
now.
Am I visible?
Yes, so I can see you, but your presentation is in the presenter mode.
Full screen.
Yes, so you have to make it to full screen. You can go it. I think you can turn off the presenter mode. Just go on to the share.
Now it's okay.
Just let me see. It's not. No. Again, so I'll tell you. Go to the display settings and turn off the presenter mode. It's on the left top. On the
next one, display settings.
Just the display settings.
Yeah, the next one. Yeah, you're coming to the
next one. Just click this. I think you should see the option there.
So let's go with this view only. No issue.
Yeah, okay. We are fine, but can you just try once? Display settings?
The panelist appearance. Yeah.
No, just try with the display settings. There's a button which is on top which we can see. Display settings.
Yeah, display setting. Mil gaya.
Yeah, so swap presenter view and yeah, now we can see. Great.
Off. Minus. So, good evening to Mumbai Pain School and all the panelists, all the person who have joined. So, I will be speaking against the motion whether cancer pain MIPSIs are essential components. So, I have a different opinion from Dhruv. I will rather say that they are not essential, but they can be used as to supplement the analgesia, and they can be an integral part of cancer pain management. My main evidence will be the World Health Organization website, where the proposed WHO ladder, as it was proposed in 1986, and it has been in use for more than 27 years into the clinical practice, and it was proposed that it has only 3 steps. So my question with the other speaker is, where is the 4th step? Moreover, according to the validation of the WHO organization guidelines for cancer pain relief during the last days and hours of life when the patient is having advanced disease, so they have said in 75 to 80% of the cases, this pharmacotherapy is useful, and only in certain refractory cases, these interventions, basic interventions, can be tried as to supplement the analgesia. Another study, it is also validation of World Health Organization guidelines for cancer pain relief, a 10-year prospective study, although it was published in 1995. It has also said when there is advanced malignancy, and in Indian scenario, commonly patients are being referred in the advanced stages only. So the role of this palliative radiotherapy and these minimally invasive interventions, there is a minor role according to this study. There are certain points which have to be answered. So first and foremost thing is the WHO stepladder, which is there on the website, it has no interventions. So it is a 3-step ladder. There are only 2 to 3 research papers in which they have recommended to include a 4th step, that is interventions or the neurolysis. Second, everybody talks about the integrated approach. They always talk about the integrated palliative care approach into the standard oncological practice. Nobody talks about the integrated cancer pain interventions. Thirdly, if you want to plan any intervention, they can be planned with a specialist palliative care person who has been trained enough to do these interventions and has these expertise. Fourth thing, you people are also encountering this thing that if you say that you will put injections into the spine or near to the bone part, no one is ready at first instance. Next point is access to services. If somebody is practicing at some district hospital, some small nursing home in a remote setup, then the access to services like C-arm or ultrasound, it is not enough. Dhruv also said about the financial issues of financial issues. Let me tell you, in the Indian scenario, if you are working in a tertiary care setup, when the patients are referred to you in their advanced stage, they are financially drained. And at that moment, these opioids and the adjuvants, they remain the mainstay of treatment because they are less costly also. So definitely interventions will increase the cost of this treatment, especially in the advanced stages. Next, if we say that in cancer pain, these minimally invasive interventions, they can be planned. So my question is, as you said that there is a downward slope of the ladder also, but in my practice and what has been written in the text, the medicines which we are giving to the patient, they cannot be stopped, especially in the last stages of the life when the patient is having advanced malignancy. You can plan intervention, the breakthrough pain episodes can be reduced, but they cannot be zero with these interventions. Now, the most important question, if a patient comes to you that the patient is having breathlessness in CA lung or lung metastasis, or if the patient is having GI symptoms like nausea, vomiting, constipation, so this will also increase the pain. So if the symptom burden is high, can any MIPSI can be planned for such intervention, for such symptom burden? And in palliative care, as a pain expert, this is a part and parcel of care in cancer pain. The next thing is, if we say about the holistic approach to cancer pain management. So we all know that initially there is anxiety, there is fear with the fate, fear of death, fear of the starting of the treatment, and later on this vicious cycle goes to depression. Psychological burden, it becomes very high, not only for the patient, but also for the caregiver. There are spiritual burden as well as the religious issues. So for these psychological burden, is there any MIPSI which can be given? Next thing, pain is common in around 60 to 70% of cases, and it is usually associated with difficulty in breathing, that is known as dyspnea or breathlessness. And in such cases, the important thing is, if you want to plan for some intervention with this breathlessness, with a respiratory rate of more than 30, can you make the patient comfortable and plan any MIPSI for such cases? The most important thing, you will get patient when they will have progression of disease. Like, for example, I want to introduce two examples here. Like, for example, CA pancreas. You said that there is a level 1 evidence for the celiac plexus block. So if the patient is having CA pancreas, the liver is also involved, the omentum mesentery is involved, patient is having moderate amount of ascites, the whole abdomen is studded, lymph nodes are large, causing obstruction of the lymphatic chain, and there is bilateral lymphedema. There is 260-degree involvement of the inferior vena cava as well as aorta is involved. So for such cases with this ascites and this much of disease, will you plan this level 1 intervention? Second case, metastatic CA prostate patient. This patient just came 1 week back to our institute. Patient is having multiple lytic and sclerotic lesions in the spine. The cervical, thoracic, lumbar as well as the sacral vertebrae are involved. There is anterior wedging at D5, D9, D11 and L1 vertebrae. Multiple ribs are involved. There is a pain generator with the metastasis present in the acetabulum as well as the scapulae, and the patient is having more than 3 pain generators. So can any intervention be planned for such cases? How many interventions will you give? And if with disease progression, if after the intervention patient dies in next few days, definitely the blame will come on the intervention. So timings are also to be decided. Recent studies published in New England Journal of Medicine. They have shown, this was a study on CA lung cases, and they have shown that if patient having serious illness and cancer, and if they received palliative care, they lived longer than those who did not receive this care. These all studies, they are focused on palliative care, not only the interventions. Every research paper, if you have seen, the first and foremost thing for the pain control will be the WHO ladder. Later on, next paragraph will say the communication, then the hopes, realistic hopes, then defining the goals of care. And last paragraph of 90% of the papers, they will say that they can supplement this analgesia with interventions. So they hold a place as supplements, not an essential component. Lastly, I will say that what palliative care definition says: expertise medical care, which can be given by a registered medical practitioner. Who is a registered medical practitioner? A MBBS person who is registered in the MCI, or a dental person who is registered in the dental council. So what are you thinking, that if these people, these registered medical practitioner, if they are working at a district hospital and they are allotted this palliative care ward, so will interventions be given by these people? Answer is no. Next thing I want to emphasize, that there is a national program of palliative care, and this national program of palliative care, it says that this palliative care should be done as a multidisciplinary approach, and it should be integral at all healthcare level. These healthcare levels, they include first the tertiary care centers, second they include the community hospitals, and third at home. So for the next two things, the community hospitals or at home, will you plan any MIPSI in such care settings? And this photo is also taken from the WHO website. It says better results in terms of cancer pain and symptom management. Symptom management they have included can be achieved when this palliative care is introduced at an early stage of in the course of illness. However, it is difficult in the Indian scenario, because commonly patients are referred late when they are on the third step of the ladder. Then an approach tailored to each individual. This word is usually used for the opioids titration, and it is adopted together with disease modifying therapies. And by this pain relief by early palliative care improves the quality of life of these patients with cancer. And below you can see what is the hashtag. Hashtag is cancer, hashtag is palliative care, hashtag is not MIPSIs. So this is my last slide. As you can see, you must be thinking why I'm so keen to say this palliative care word. Definitely palliative care word will be used if there will be management of cancer pain. And as you can see in this picture, what has been written, pain relief is just a part. The umbrella organization is the palliative care. Moreover, apart from pain, what other things have to be taken into consideration if you want to give a good relief to the patient? So some non-curative therapies like non-pharmacological therapies, they can be used like TENS and acupuncture. Apart from this, patient-centric approach should be used. Stresses, especially the physical stress in the form of the symptom burden, as well as the psychological things have to be reduced. Alleviation of the symptoms, psychological interventions like behavioral therapies can be included. Life of the patient, especially the last hours and days, they have to be taken into consideration. Nursing care, your patient will be ECOG for more than 18 hours on bed. They might have nursing care issues. They have issues with self-care, and you are just thinking about the cancer pain interventions. No. Then the mental stresses not only of the patient, but also the caregivers. And lastly, in life-limiting illnesses, we are talking about the cancer, this despair, this fear and everything have to be taken care. So I will just say interventions, they are not essential. They can be an integral part of the cancer pain management to supplement the analgesia. Thank you.
Great. Thank you, Dr. Sunny. And we almost finished in time. So both of you, now we move to the rebuttal. So Dr. Sunny, you have the first chance for rebuttal. You can start saying pointers. Yeah.
So my dear friend Dhruv, he said that first thing, time to accept the changes. So definitely we will accept certain changes, but certain points are to be answered, as it was in the presentation also. And he was talking about this WHO stepladder. I have also read the history for this presentation. So what is written? WHO stepladder was introduced in 1986 by the World Health Organization, and it is now supported by more than 27 years of clinical experience. Several new editions of the recommendations have been published. They are just the recommendations. First thing, it is safe and beneficial for chronic non-cancer pain also. In 2010, as he rightly said, bidirectional use of the ladder was also introduced. So I already said that you can plan intervention for a patient, but if you are planning intervention, my main question is, can you stop that morphine? Can you stop that gabapentin? Can you stop the bisphosphonates? What is being given to the patient for this bony fracture or lytic lesion? So this is important. Now there are 2-3 additions. It is not just about the intervention. 2-3 additions. In 2014, this paper was published. Patient therapeutic education, placing the patient at the center of the WHO analgesic ladder. So patient's education, not only about the interventions, about the opioids. He was telling about the opioids. It is important. Next, the integrative medicine therapies. Apart from this, and what they have proposed that minimally invasive interventions, they can be used in step 3. It is recommended before upgrading to strong opioids. But the question lies here. In the Indian scenario, I have been working in the cancer pain setup for last 6 to 7 years. And at this center also, what I am getting that patients are generally referred late. And these opioids like morphine and fentanyl, they have already been started. Patients are referred in the later stages when they have advanced malignancy, and it has been written in multiple texts that in the later stages, if you plan any intervention, they will work for just few days. If the interventions are planned in the early stage of disease, then this neurolysis will work for 3 to 6 months. But in the Indian scenario, if you are planning, first of all, these interventions are risky in these stages. And if at all you are planning, they will not work for even a 1 month. Now, 2 things, what my dear friend said was that time to accept, yes. What about the community level? You are sitting, I am sitting at a tertiary care center. So we are living in a metropolitan city. So we can plan intervention. But as I said, the palliative care definition says that MBBS or BDS doctor who are registered, they can do this palliative care and cancer pain management. So how will they perform when they are in the district hospital or the community care centers? Second, I already said patients are usually referred in advanced diseases. Interventions like neurolysis are very risky for these patients. 4th step, what he said, it is just a recommendation in 2-3 papers. Even the IAPC and ISSP guidelines which are published, they also have a picture of a 3-step ladder only. Not only the WHO, these Indian guidelines also have a 3-step picture. Next is challenges, he said about the opioids. Everywhere it is written that opioids, they are the mainstay of management, especially to reduce the financial burden of the patient. Challenges, if he is saying about the challenges, what about the challenges to be taken care during these interventions when the anatomy is very poor? As I said, that CA pancreas, I know that there is a level 1 evidence published in the ISSP guidelines for the celiac plexus or splanchnic neurolysis. My patient had metastasis in the omentum, in the mesentery, in the liver. and there was involvement of the inferior vena cava as well as the aorta. So in such cases, will you plan intervention? And if at all, if you want to plan this sympathectomy, क्या वो झेल पाएंगे उस sympathectomy को if they are having this electrolyte imbalance? Next is, if you plan these epidurals and intrathecal infusions as is written for the intractable pain. So if you are talking against the opioids, are you not going to give opioids through this epidural or intrathecal route if they are on pump implantation? My dear friend, you will also give morphine in that pump along with ropivacaine. Next is, these interventions are good only in expert hands. And it is also a recommendation in the ISSP guidelines. They have written this point, only when there is expertise, not at the community care level or the district hospitals. Then opioids are available at chemist also. You have to know the guidelines. You have to fill the DD12 form properly. Okay. Then you need 3 prescriptions. 1 prescription will be in the file. 1 prescription will be for the patient because he will carry this morphine. And the 3rd prescription will be with the chemist or the person who is dispensing. So previously it was difficult. Now it is not difficult. Definitely we have to take care about this opioid epidemic like it is happening in the US. One thing also I have already said, you cannot stop the medicines after the block. इस पे तो मेरा 100% है. You cannot stop the medicine. Pharmacotherapy has a role. And when the patient will have breakthrough pain episodes, I had implanted pump into the patient. Breakthrough pain episodes happen with that pump also.
Okay, Dr. Sunny. Yes,
Okay,
sorry to. I think you covered it really well. So we'll invite Dr. Dhruv for rebuttal.
So to rebuttal, I'll first and foremost, I would like to say a few things which I think he has misinterpreted, right? So there are few things which I totally agree. There would be a situation where the drug will be stopped. I never ever said that these are going to replace medicines, right? So that is clear, that is done. Second, I would also like to request him that please, Dr. Sunny, you are more like a brother and a guide for me when it comes down to cancer pain. But the topic, my friend, was related to pain. It was not about palliation, right? So Dr. Sidharth's topic was very clearly talking about pain, which is a part of palliative care. Within the big umbrella of palliative care, pain was the topic that we were. So what I would say is that you regressed from the topic. That is one. That was second point. Third thing was, you talked about, sorry if I may offend you, tell me one thing which you are using since 1986. One damn thing which you are using from 1986 till now. You talked about 2 papers which were 95 and 91. We were doing interventions in 95, 91 based on blind anatomical landmarks. The interventions have gone ahead, right? So that is one. That thing was very thing. You talked about phobia about injections. There is phobia about opioids also. And your entire talk was based on opioid. Bhai, opioid hai kahan? How difficult it is to get opioid, even in peripheral setups. You tell me a state like Punjab, you cannot get tramadol. Leave about morphine. Morphine nobody wants because there is no margin. We have to think on those aspects also. Na? We can't sit here and say, ki bhai, opioid de do. Hai kahan opioid? Right. So, and that is a very thing. And you talked about Indian scenarios. I never challenged it. I never said that every district, every place, every hospital, everybody at any place you can do MIPSIs. No, you can't. But first we have to accept. I drive a CNG. The future is electric. Today or tomorrow I have to accept it and get one. And my dear friend, you also at some point of time will have to accept the future is. When it comes down to pain, I repeat, the topic was for pain, cancer pain. Palliative medicine was never challenged. And I agree about the psychological things. Those are part. I never ever challenged any of that. It is about pain. And if we have to cut down the doses of our drug. If we have to cut down the doses, the side effects of our drugs, of our opioids, then we have to do something for better pain relief, so that we cut down the medicines. Automatically, the side effects will come down, and you would agree that since you are seeing more patients sitting in a tertiary care center, definitely there are challenges. We get old patients, we get all screwed up patients, and that was, sorry to say, I tried to be dramatic with my presentation, but Dr. Sunny, your two cases were purely dramatic. You can put every goddamn thing inside the case and say, "Ab kar karke dikhao." I can't, and nobody can. It is just adding कि भाई you give me a situation where से आप करके नहीं होगा, नहीं हो सकता, and it is patient centric. Pain medicine, any medicine for that matter, has to be patient centric. So it is not only cancer pain or palliative. You have to be, as a doctor, it is our duty to be patient centric. So that was never challenged. Talking about palliative care cost, though you have said me in private because we have good terms, what is the cost of palliative care in the setup? Is it comparable to a simple MIPSI that we provide? I don't think so. If your palliative care is equal to cancer, firstly, it is not a forum to discuss palliative care. So challenges are in both fields. I agree. Palliative care, I am not challenging it. Pain is just a part of it. But at the same time, what I want to say is when it comes down to pain, we cannot underestimate the MIPSI. And sorry sir, but do not do the cherry picking. When it comes down to the WHO thing, आपने कहा वो तो 86 से चल रहा है, 86 से unidirectionally चल रहा है. WHO की on the website of WHO, it is still unidirectional. It has not become bidirectional. It is bidirectional only in the few articles that you say, where you said that now there is a fourth step, and then you talk about studies which अब third में वो fourth आ गया. So definitely we will all agree that a lot of things need to be done, but the first thing is accept. We have to accept when it comes down to pain. We will definitely, interventions will definitely complement medicines, come down the uses, and obviously if the dosage comes down, you would agree that their side effects will also come. Therefore, challenges are there, and we will fight them out together as brothers in our fight against cancer pain. But the first step has to be an acceptance that yes, they have a role and it has to be done. Thank you so much.
Okay, Dr. Dhruv, thank you for covering all the 3 points, the rebuttal very well. So as a moderator, I get a first chance to ask the question. Dr. Sunny, I have a question for you. So as we said, it is a little difficult to it's difficult for getting opioids now in Indian scenario as well. And not all the times, we get patients in their last stages. So we do get, as more and more, oncologists start accepting pain and palliative care, we do get patients in our early stages. And so how much do you think, based on these laws, are they getting difficult? Because in my organization, I had to change one, fentanyl license from one brand to another brand, and I was told that you still need a new license for that. You cannot change the diuretic patch to the other brand. So what's your experience in that, getting or procuring licenses at the small organization, if it's not a government organization? How difficult it is that in your experience?
Now, if you are talking about my experience, I am sitting at a tertiary care center. We have our own license for this. We have a team, we have dedicated persons who are well trained maintaining these registers, and they are meeting the drug controller well in time for further indent. So previously there were difficulties. Now, as he already said, he has quoted the paper from Dr. Rajgopal also. Thanks to Dr. Rajgopal and Dr. Sushma Bhatnagar. Nowadays, there are no difficulties. If a person wants to procure these opioids with all these channels and with a team, so they can procure. However, if you want to change the brand, like you are also working in a tertiary care center, you must also be having a team who is taking care about these licenses and all. You have another option with you. If you don't want to change this Duragesic patch, as I already said, you can just fill a DD12 form. My very dear friend, my mentor, he is into the home care visits only. He is getting calls and he is going to the home and he is prescribing morphine as well as these fentanyl patch to these patients, and he is doing dose titrations for these home-based patients only. And he is not finding any difficulty. Proper filling of the form, proper notes, start at a low dose, check the parameters well in time. Follow-up visits are very important, and never ever give more than 10 days dose to the patient. Initially, you give just 3 to 5 days dose, because in the next 3 days, you have to titrate by increasing it by 20 to 25% of the total 24-hour requirements. And then when you have built a rapport with the patient, you increase the medicine and never ever give for more than 10 days. So it is not at all mushkil. Moreover, as I will again go to Dhruv, he said that I was talking about palliative care. My dear friend, if you are talking about cancer pain, you cannot just stick to cancer pain management. You have to talk about palliative care. You have to talk. मैंने बोला ना, if a CA lung case comes to you with breathlessness, patient is coming and he was just getting settled with an anti-anxiety pill, a lorazepam in a 0.5 milligram dose kept under a tongue, and his pain was getting settled in CA lung.
This can go on.
Very well taken, and I think the rebuttal time is over yet.
So that's
if that point is very well taken, that we do need palliative care. But as Dr. Dhruv also said, that this discussion was just related to the pain, and I know it's like we can't get away from managing other symptoms. You do have to take care with the medication, of course. But if it just comes to managing the pain, for example, in the early stages, patient just have the pain along with a little bit of anxiety. What do we need to do at that stage? I think that was the little debate that was coming from.
Now the debate is that what was the topic? The topic was whether it is essential. I am saying that it is not essential. It is to supplement, and it can be an integral part.
Right.
It's an integral part, but it is not at all essential.
Sorry, it's just a wordplay. If you're good in your language, you can word around integral, essential, this and that. Boss, we need it, we need it. If you want to use it, you use it. It is not always, but it is not always not that you will use everything that you have.
Recently on a forum, I said we always talk about the integrated palliative care approach along with the comprehensive oncology services at the early stage. I also said we should also think about the integrated pain and palliative care approach.
Yeah.
So it can be integrated, not essential again.
Now is the time for the second question, I guess.
Yeah. Next question.
Dr. Sidharth can ask the second question.
Yeah, so my question is to both of you. First, I just want a number, just a vague number. So you are, both of you must be treating a lot of cancer patients. So what is the morphine daily, average dose, total dose, which, your patients are having?
10 to 20 milligram, 4 to 5 times a day. That would be my average. But
So
since
40 to 80 milligrams max.
Yeah, but I'll tell you, first of all, I don't see such kind of serious patients which will require inpatient or in-hospital stay. So that is one thing. And secondly, there is going to be, I have to admit, the patient who come to me are generally not so advanced, clinically more stable. Secondly, they come with a intention that sometime kabhi intervention bhi aayega role mein. But yeah, that is on an average amount of morphine.
Okay, so Dr. Sunny, your this thing, because
on
the basis of this answer, I'm going to ask you a question. So that's it. Yeah,
I will just add. You will get patient like I am sitting at a cancer.
I'm not asking any explanation. I just want your thing. That's it.
मैं अपना ही बता रहा हूँ.
डोज बताओ, नंबर बोलो.
नंबर बता रहा कि चालू तो करने दो.
अरे नहीं यार, जल्दी करो.
When you get a patient, sometimes you have a start at a very low dose. So you
Average
are just giving 2.5 milligram 4 times a day. But
just
that patient,
an
that
idea.
CA pancreas, that CA pancreas patient, what I told you, it was an original patient. Now he is no more. I was giving around 500 to 600 milligram morphine equivalent in a day.
See
And
what
on an average, it is around 150 to 160 milligrams in a day.
160 milligrams.
Morphine,
Okay.
oral morphine equivalent divided in patch and the dose.
Understood. Now my second question, the second part of this question which I wanted to ask is that both of you tell me what is the ideal time when you will like to do your intervention.
Very good. Sir, shuru kare, senior. I'll tell you what. If you talk about the opioid doses, I would be more interested in what is the sort of a life expectancy, what are the other medical comorbidities. If the life expectancy is more, then I will be aggressive towards it. It has nothing to do with morphine dosages, honestly speaking. Right? So if the patient is in terminal stages, uski morphine ki requirement, if sab kuch fail ho jata hai, Dr. Sunny will agree, then also this morphine requirement goes down. Because it is not being metabolized, all those things happen. So that will, my intervention will depend upon the life expectancy. That's it.
Okay.
And the tolerability of the drug. Some people are just not able to tolerate drugs.
Okay, so I think there are various factors. What I want to know is about timing. Supposingly that we assume a good life expectancy, because otherwise the intervention we are not
exactly
to do it only. So we assume that life expectancy is okay. Now you tell me what is the stage when you will like to add the intervention and not escalate the morphine to the max possible. Do you wait for the side effects to become intolerable?
No.
Where do you draw the line? That's my question.
See, the thing is, life expectancy is outside. If at all the patient's the side effect starts bothering the patient's day-to-day activities, then I will not hesitate to offer him an intervention.
Okay, so I think you say that it's a side effects. What about you, Dr. Sunny?
If the patient has come in the early stage, if the patient has been referred in the very early stage of the disease, initially, like for the visceral malignancy, like CA pancreas or cholangiocarcinoma, disease has not spread. In that case, first I will start the pharmacotherapy. Opioid titration, first I will start. But in this per se case, because I know there is a level 1 evidence for the celiac plexus block, so I will start communicating with the patient and the attendants and will give him or her an option that this can be planned in future. First, I will like to build the rapport with the patient. Second thing, if the breakthrough pain episodes get increased to more than 7 per week, despite these opioids and after their titration, this is the time when early intervention should be planned.
Great. So here's the point, which is a very good observation and probably a practice which I wanted to make, that there has to be some sort of a criteria. So those of us, I think we have most of the audience, I'm damn sure there will be very few oncologists who are going to see this debate. For them, the debate is already settled. So, but if for most of the people who are doing or are wanting to do interventions, I think the timing is the most important part. And as they say, the palliative care does not start when the person is reached the stage 4 of the cancer. It starts from the day 1. That means your only the kind of role which the palliative physician plays, it changes. So similar way, even for a pain physician, as Dr. Sunny has mentioned, that your rapport building and everything has to start at day 1. So if there is somebody who is looking after palliative care exclusively, you are lucky in your institution, then in that case, also the referral to the pain physician should come on day 1. If it doesn't come, then it's extremely going to be difficult to identify the point when to intervene. And maybe when you are ready to intervene, that time the patient is not ready to accept the intervention because patient's condition may not permit that. Or maybe this condition may be financial, maybe physical, maybe emotional, whatever all components of even palliative.
Dr. Sidharth, I would just like to add, I think these are basics. Building a rapport with the patient, especially if you are dealing with pain or palliation, both of them you should have an empathetic attitude. That goes without saying.
I'm just saying about the timing of the referral and when you want to think about intervention, when you want to inform about the patient, because being a specialist, when you on one hand you are saying that I'm going to only intervene in pain, I'm not going to cover the whole palliative care spectrum, and on the other hand you are going to get the referral, or probably patient may die and still somebody may meet you on the way and say, oh, hame to pata hi nahi tha, doctor. Otherwise,
See, I'll tell you what. I always end my anything. Now it is going general. So always at the end, I always give hope to the patient. कि देखो अभी हम इससे शुरू करते हैं. We'll start with this and see how your body responds. And अगर वो कहता अब क्या उसके बाद भी कुछ कर सकते हैं, क्या कर सकते हैं हम कुछ कर मतलब then I try to explain based on the educational status of the patient. I'll try to break it down into simpler ways, but always specifically in cancer pain, I have always tried to end my discussion, my consultation on a positive note, because I personally feel whether you are into pain or whether you are into palliation or you are doing integrated practice, whatever it is, for cancer patients suffering from cancer, we are the only doctors who give them some good news, some hope. So we should always end, at least that's what I do, that there is going to be, we will do something, we will find a way, whatever. Agar ye mujhse tolerate nahi hoti, then there are patches, then if this not happens. So I always try to not only communicate to them, but at the end of the day, always give them hope.
Example, one question from, I guess, that was just.
I think we can omit the question because, there should not be any drug related discussion. All be this, let's focus on the MIPSIs. There are lots and lots of forums, and we have got complete journal clubs also on devoted on the topic. So I think if there are any questions on MIPSIs, we can take that, and timing of the MIPSIs. Dr. Sunny, I'm very, very happy to hear this more than 7 per week. I don't know about others, but I've heard this for the first time. So any such other practices when you decide to go for interventions, because that seems to be a very good starting point. Dr. Aanchal, were you knowing about this? I mean, I was not knowing about it. So very nice.
That's why it's good to
Sir,
have
experience बोलता है, sir, experience बोलता है. And the thing is, he can correct me if I'm wrong. I think he's one of the only person who gets to sit in a tumor board. He sits in a tumor board. I'm not aware, Dr. Aanchal.
No, I do sit in the tumor board as well.
Good. Because that was for the first time I came to know about him.
And,
no, you can sit on the tumor board. You just have to go, and I feel that the oncologists are more open to this kind of a participation rather than you forcing in your way with interventions. Because constructive, this is always welcome. That's the very purpose of.
There's one more change in our tumor board. We are also presenting our cases in the tumor board among the oncologists.
Yes.
This is also a practice.
That's very good. That's very good.
No, but I think that is what needs to be done. And I think in my practice, I'll try to include more of that. I'm not able to find my availability at that particular time, but I think that's the integral thing which we need to do if we have to succeed, because that's the point. I have attended a few tumor boards by missing my other practices, and but sometimes I just pushed that I have to attend, and you will be surprised to see that in a tumor board, those of you who have not attended, even there is lot of variation in the opinions of the radiation oncologist and the surgeon and the oncologist, medical oncologist. So and they all kind of try to come together to a conclusion and have a healthy discussion. Sometimes it gets heated up also, but it's all in the best interest of the patient. So I think
it adds to everyone's knowledge. It adds to everyone.
Yes.
So,
So
Dr. These cases you present, are the cases not already been presented by oncologists, because they are referred to you from those only?
We are getting actually 2-3 types of patient. One is what we are getting as referrals. Patient is being admitted in the daycare ward or the IPDs, and they are having pain or they need palliative care. So one is this type of referral. Second referral is when we are planning our treatment also in between these oncological cases. Like if the patient, we have a protocol at our institute, if the patient is getting chemo, and if we want to plan, now I am not against the intervention. If we want to plan intervention,
no, the thing is not ended yet. No, by the way, we are just talking because the audience has not asked the question. So that's why I think we are. That's why we are. Yeah.
So in that case, we had a protocol that after this chemotherapy, we will not do any intervention or admission for next 7 days. And when the patient is coming after this chemotherapy, we get this CBC done, because there might be bone marrow depression after this chemotherapy. And we always get a KFT done along with the calcium and the magnesium, because there are chances of hypomagnesemia and this hyponatremia in such cases. Then only we admit. And if we admit these patients, like for example, recently I admitted a case, he was having a sodium of 121 on admission, and he was planned for intervention. So initially for the 24 to 48 hours, this sodium correction was given to that patient, and then the intervention was done on the third day after this correction. And thirdly, what we are getting are references. Patients are coming from outside the institute now to meet the palliative care specialist at the center.
Yeah,
So
I'm getting those references as well, but most of those cases is just like, we just need the pain management and we don't need any chemotherapy, because it's their perception that they have, understood that at the age of 80 chemotherapy, it's their own decision. Like nobody has given them. They directly come to me just for the pain management. But do you present those cases as well? Because they clearly said no to chemo and radio. Like.
One of my patient was suffering from the CA larynx. Even that tracheostomy was done by us for that patient. He was only and only under the palliative care department, and he survived for 2.5 years only on palliative care. So that, like such cases we present in the tumor board ke only palliative care se bhi survival बढ़ता है.
Right. I think that's the important thing. Like if you have a bigger and bigger team, more pressure or more.
Definitely, we have a team of 5 members at our institute. We have a nurse practitioner also. It's a protocol. If whenever we admit the patient, the first person जो कि उनको देखेगा is our nurse practitioner.
Okay, guys. So I think.
But ma'am, just to add it diplomatically, correct, he will not say it, but this kind of a practice is only possible at the place that he is working, because this team and his understanding is very good. The bigger original RGCI does not have it. I can say it, he can't.
हमारा duplicate नहीं है, हमारा भी original है.
नहीं, the pioneers, the so-called the parent, the right word is parent organization does not have one. It is just these guys who have tried to build and develop the culture of trust over. It's a talk about trust.
That's the role of developing a rapport. Because look, what the idea behind holding this debate was that rather than pointing fingers at other, why don't we introspect and see whether we can find real good use cases, for our interventions, and if they are good use cases, if the patient is going to benefit from them, then if there are clear indications. Right now everything is ambiguous, but like what Dr. Sunny mentioned, this specific point, undisputable points like X number of breakthrough pains per week, or maybe some ABC diagnosis. So I want to encourage the people who will watch this now or in a recording phase that think of those lines and just come up with those things and maybe publish it, share with your friends, not necessarily on big fora, but just WhatsApp them. Look, I found this, I'm using this, I'm doing this, and probably it's working. So what do you say?
Points like this can put increase the understanding of oncologist as well, and he can also say, on my pain management, this number of breakthrough pain is happening, so why don't you take care of the patient along with me, something like this.
Change आ रहा है मैम, change हो रहा है.
Right, I agree.
हमें अपने अंदर भी change लाना पड़ेगा.
That's what I said, that we start with
totally agree.
Stuff. Great. Okay, so I think we don't have any question. Let me just quickly check on the social media. So we have some 8 or 10 people live on Facebook as well. So let's just check if they have any questions which are posted. Otherwise, we will just go to the next part.
Wैसे on the lighter note, we said yes because me and Sunny wanted to meet, and it was not getting possible on a real platform. So we thought of meeting up on a virtual platform.
So that's I hope that we could
right now also we are hardly around 500 meters.
Yeah, okay, so you stay 500 meters apart, right? Is that
no he's
I'm at the hospital only, na?
I'm home, so okay, I'm very close.
Okay, great. So there are no questions here. Okay, so this is just a comment that Dr. Smita is saying that she's got pain management with excellent post-surgery and radiotherapy. So I think, Dr. Smita, are you an oncologist? Because I think for us, pain management has always been excellent. So, so I think that's it. Okay, guys. So now we have a couple of still a lot of attendees here. We have one question from Dr. Anand. I'll take that question, and any of the speakers can answer. How do you titrate the dose of neuropathic agents and opioids after pain intervention? So that question I'm going to take live. So I think it doesn't change, but what do you say? Nothing changes after the intervention. Also the titration remains the same. What do you say?
Yeah, at least post intervention, I would like to wait for at least 7 to 10 days, or to be on a safe side, for around 2 weeks for the intervention to kick in, and then gradually think about cutting down, if at all, if we have.
One thing is very important. Whenever you go for this neurolysis with this alcohol for the celiac plexus or the splanchnic, you have to tell the patient that there might be possibility your pain will increase on the 5th to 7th day.
Yes.
So for that period, for that breakthrough pain episodes, that opioids have to be increased for those moments. That is important. And many times you need to add some anti-inflammatory medications as well as low dose steroid also.
Again, I think that is the basis. Whenever we are prescribing drugs for a cancer patients, we are trying to talk about baseline also and breakthroughs also. So breakthrough has, whether it is with MIPSIs or without MIPSIs, breakthrough has to be taken into account, and rescue medicine has to be prescribed. And because
definitely
बढ़ेगा. Intervention के बाद दर्द होता ही होता है. और जैसा उन्होंने बोला, it is going to be there with everything. So it's not a magical pill कि आपने दिया और था करके. There is an event, even if you have an absolutely successful intervention, the patient will never have 100% pain relief. So let's be clear on that also. And morphine will never stop.
Important. This should be a part of every communication, that the target is 50% pain relief, because at 50% pain relief, patient can have a sound sleep at night.
So I think another point which I want to make here is that your dose will drastically go down if there is pain relief, and at that point of time your drowsiness and dizziness and all those things will increase. Because so
Dr. Sidharth, I think Dr. Sunny will also drastic कुछ होता नहीं है, sir, gradually होता है. मतलब ऐसा dramatic कुछ नहीं होता. It is a very slow process. So that is why, and we have to be careful also when we have
some experience with the splanchnic RFs, wherein the things have been quite fast. In fact, I have changed my practice to not putting any alcohol after a splanchnic RF. This is a quite different practice from most of the places. In fact, I was reading, we will discuss, I think, one of the papers where they are going to discuss with RF with alcohol and just plain RF. So, the effect is quite, dramatic as compared to probably putting in the alcohol. So this is my short experience.
No, it's my practice as well. I just do splanchnic RFA, no alcohol or no.
If the patient is on around 100 to 120 milligrams per day, so the dose in a few days, in next 15 days, you can reduce the dose to 60 to 80 mg. इतना ही फर्क पड़ता है.
But assessment 15 days पे से पहले, generally I do not do earlier than 15 days. I will ask them ki for after 15 days.
So agreed, but that also makes a very valid point, which is especially helpful, or rather to be pointed out to our oncologist friends, that they should not say अरे वो दवाई तो बंद ही नहीं हुआ, तो हमारा तो intervention का कोई फायदा नहीं, पहले भी वो दवाई खा रहा था. So he was having the medication before also.
In every meeting, you have to tell the patient and the attendants, दवाई बंद नहीं होगा, ये last breath तक चलेगा.
Yes. So that's the point which you need to make out, that it is going to just add to the multiple things which you are doing. This is one of the modalities.
Supplemental है.
Yes.
मानो तो है, आप तो मान ही नहीं रहे हो.
मान लिया भाई.
आप तो छतरी के पीछे पड़े हो कि हम छतरी खोलेंगे. भैया हम तो सिर्फ एक की बात कर रहे हैं, पेन की.
Okay, so guys, now let's have the we still have around maybe 20-25 people who are just now with us. So I think let's have this small poll wherein let the audience decide. So guys, you all can also vote. So just Don't end the poll. Those of you who are hosts will get the option to end the poll. Don't end the poll. Just vote. So only the Zoom people who are attending live with us, they can vote here. So I'll give you say 30 seconds to vote, and meanwhile we wait for your votes. Okay, 5 of you have voted, 6 now.
सर इतनी देर तक कर क्यों ना, घर जाने में देर नहीं हो जाएगी? सनी सर, सनी सर, घर जाने में लेट नहीं, घर कब तक पहुंचोगे? 12 बज जाएंगे।
हाँ, 1 घंटा लगेगा।
सर होप देना आसान काम नहीं है। So it's a life of dedication.
Dedicated palliative care physician.
Yes, so it's a life of dedication. Anyway, the medical profession is always a life of dedication, but I'm also sitting in my clinic. So
नहीं सर, खुद को तो पेन नहीं होना चाहिए ना, इतना काम करो जितना खुद को ना पेन।
हम चाहते थे ध्रुव के पास रह के प्रेजेंट करें।
हाँ, मैं आ जाता अगर आप बोलते तो। Actually ना, I'm not playing a spoilsport. I have an early morning flight tomorrow for Calcutta.
अच्छा।
Guys, just 10 seconds remaining. Please vote for your favorite speaker.
Favorite तो सनी साहब ही है सर। Genuinely speaking, I've learned a lot and I've got a very good perspective about a lot of things.
Great.
But opioid नहीं मिलती है तो पक्का है, इस पे आप मानो चाहे ना मानो।
Oh yes, I wanted to make a point before we end the polling. Dr. Aanchal, that the license is never company specific. So let me make this point very clear.
I also think so.
The problem was, it is drug specific only. Why you face that problem was that one particular company, I will not name it, has the morphine, has the fentanyl patch in 12 micrograms per milligram. The 12 mcg per hour release preparation. So the other one has 12.5. So when the license is mentioned, they write 12, and if the 12 is mentioned, they will give only for that particular company, because only that company has that one thing.
Got it.
Another problem which you will have is with Morcontin 30. So that is available only from one company. So no other company will make. They'll make 30 mg regular release, normal release morphine, but only one company will make 30 mg sustained release morphine, and that's why they will only be able to supply that. So that's
even if along with the drug, we have to mention the dosage in the
yes.
The
so if you want
to
the other company to get that thing, then get in the license you have to get it changed. And let me tell you, it's not a very difficult process. Dr. Sunny gave the example of his friend. I have been doing this regularly. Wherever I go, you just have to make that format, and it is not necessary that you write that form number, this, but you write all the components which are there in that form, sign it in triplicate, write your designation, and write the complete. There are a lot of things there, complete address and everything. And if you write it, long enough, like slowly, I think even the chemists and all that, they also know that from where. In fact, one time I told my resident to write the prescription, and I just signed it. And I got a phone call from the chemist saying that, sir, ये आपका writing नहीं है, ये गड़बड़ हुआ है कुछ. So then I told that guy that.
Sir, Mumbai में कितने chemist हैं जो opioids रखते हैं? Just asking.
So opioid is a very low profit, especially morphine is a very low and the risk is very high. So I'll tell you where it will be kept. Only in places where oncologists are practicing as a group, or maybe at least 2-3 people, there only the chemist will keep it.
सनी सर, केमिस्ट कितने रखते हैं हॉस्पिटल की, अगर हम बात ना करें तो?
Okay guys, I am ending the poll now.
हाँ ठीक है.
Yeah, go on, please go on.
हाँ सर, सनी सर, दिल्ली में कितनी जगह मिलती है?
दिल्ली में मिलती है कम से कम 10 से 15 जगह।
एनसीआर मिला के नहीं, गुड़गांव नोएडा
दिल्ली में मिलती है, जैसे आपके यूसुफ सराय जो है पास में, वहीं पर 2 या 3 केमिस्ट,
3 दुकान वहीं पर है सर, सबसे मतलब वहीं पे आपको मिल जाती है।
आरएमएल के पास है, रोहिणी में है रखते हैं।
But I am sharing the results now. So this is the people who have polled. So from the polling, although I think Dr. Dhruv has won the debate, but I think it was very well presented by Dr. Sunny as well. So I think we will now.
आपको कभी मना किया मिलने तो हम पहले तो राशियां मिलवानी पड़ेगी तब मिलेंगे हम.
So I think you can see the camaraderie they are sharing. So before we end, I would like to now thank all the participants who have viewed, and also to especially to Dr. Dhruv and Dr. Sunny, who have prepared so nicely.
Thank you so much.
I think special thanks to both of you, also to my co-moderator Dr. Aanchal. In the beginning, I just forgot to even admit her, so please excuse me for that. I'm very happy to have you with us always. So thank you all. I hope this will put new lights on this topic, and I think we take good pointers to introspect and improve our interventions to make them more beneficial for the patients. Anything, one line, if you want to say, I allow you now before I go on to the next steps. Dr. Dhruv.
Nothing, sir. I think it was a good initiative in a good, interesting format, rather than going the same old way. It is not about, we might have, our approaches might be different, our way of thinking, but our goal is same. But it is a good way of interacting and learning a lot. So with everything that wherever I do, I always learn a lot. That has been my thing. And in today also, I learned a lot. So thank you, Dr. Sunny, for sharing your knowledge.
It is a bi-directional approach. कुछ हम सीख रहे हैं, कुछ ध्रुव सीख रहे हैं.
हाँ बिल्कुल सर. मैं तो कहता ही इसी बहाने तो मैं भी पढ़ लेता हूँ, वरना कौन पढ़ता है.
Great. Dr. Aanchal, anything which you like to say before we end?
I want to thank both the speakers for taking their time and adding so much to our experience.
Thank you.
Thanks so much.
Great. So guys, thank you all for joining in. Just join our mailing list. The link is there in the chat box. Join our WhatsApp group, and your suggestions, comments are all welcome to mumbaiPainSchool@gmail.com. I have received one question from I think somebody about, I think I should take it right now. We have Dr. Dhruv and Dr. Sunny also. So how do you manage the head and neck cancer pain other than interventions?
So वो तो सर अगेंस्ट वाले ही बताएंगे. सनी साहब बताओ. Sir, the route of administration of opioid will be different. That is it. But opioid will be there. Route different हो जाएगा ना. Common sense तो रखनी पड़ेगी.
कई बार जो है आपको initial dose titration, अगर OPD, if you have to do this OPD based dose titration with oral morphine, so आपको you have to crush the tablet and you have to give it sublingually around the cheek and under the tongue also. If the patient is having this feeding jejunostomy or Riles tube, then you definitely have an added advantage. Third thing is, again, I will say, if you are working at a tertiary care center, you have an advantage that you can admit the patient and you can titrate the dose with IV morphine. Start low with IV, calculate the 24-hour requirements, and then on the next day, multiply by 3, it becomes the oral dose of morphine, and then shift to equianalgesic dose of patch. And I already said in the previous lectures also, what we do, we divide the patch dose half-half. Half will be that if the total requirements are like 90 mg per day morphine equivalents, oral. So I will give a 24 microgram per hour of patch, which will be equivalent to 60 milligrams, and 10 mg normal release dose will be given in a thrice daily dose. So this is how we practice.
Great. And what about the tonsil and soft palate? Anything specific for that? Because there is nothing which we can do in terms of intervention. Any intervention which you have ever tried for that?
Interventions, if at all you want to plan, if it is for the base of the tongue tumor, you can try this glossopharyngeal.
No, not the base of the tongue, but for the tonsil and soft palate.
I will not plan any intervention. In such cases, it will be the pharmacotherapical management only.
Yes.
Plus, definitely, as I already said, the palliative care. You have to take care about the candida, the fungus, everything. Maggots, even the fungating lesions can be there. You have to take care about them.
So, and initially, to start with, if the patient cannot swallow, as mentioned, I think the other routes can be used. And if then the patient can swallow at least food, or otherwise the RT can be put, and then the patient can be managed in that way. Great. So I think this was, I just got a special WhatsApp message from our colleague. He wanted to take this question up in the audience, so I just took it up. Great. So I think let's meet up next Friday, 9:30 p.m. And also we are going to have this hands-on MIPSIs in, which is our cadaveric workshop, where we conduct the training for for the hands-on procedures on cadavers, both ultrasound as well as fluoro-guided. So guys, please join us for this as well on in 16 to 18 September. I think this Sunday I'm going to put up the registration links. The seats will be filling fast, so just grab them while you can. So thank you all for joining in, and see you around next Friday 9:30 with a new journal club. We have only 2 left now for this season. So hoping to see you all soon again. Keep learning. Bye-bye.
Bye-bye. Take care. Good night. Take care.
Good night.